am Paula with the Hawaii After School Alliance, and I would like to welcome everybody to our out of school time virtual meetings. So I'm so happy to see all of you today. I am going to pass the mic to Lexi so she can introduce herself.
I'm Lexi, and I'm with the Hawaii After School Alliance as well. And I was just going to run through a couple quick announcements this morning before we get going. The first is the fourth wave of the after school and the time of COVID tracking survey for programs is out. And we know that after school and summer programs continue to face challenges as well as highlights during the pandemic. If you are an after school or summer program provider, please help us continue to tell the story of COVID-19's impact on your program, the youth and families that you serve. The deadline for the survey is this Sunday, and if Hawaii gets the 30 participants for the state, we will get individual state data. So please share your program story with that, and I will drop the link for that in the chat. And then the next announcement is on Wednesday, we had our virtual OST fair where lots of great networking as well as resource sharing happened. And so we wanted to say thank you to everyone who was able to join us, but also be able to share out the exhibitor directory for those of you who may have been interested but unable to join. The directory has the list of all the organizations who participated as well as their information and useful links that they shared. So there's lots of great info in here. Feel free to check that out. And then the last one I have is our next OST meeting is Friday, March 26th at 10 a.m. or yes, at 10 a.m. Sorry. And this will be on discussions of racial equity. We will have Liam Chen join us, and he's a community security and police reform expert. So we anticipate a time of kind of diving in deeper to this heavy topic and just being able to have discussions on racial equity. So we invite you all to join us for that, and I will drop the link to register for that in the chat as well. And so that's all the announcements that I have. Paula, I'm going to pass it back to you to talk about the American Rescue Plan.
Thank you, Lexi. And I would like a second for Jen to introduce herself. She's been behind the scene of organizing before I talk about the American Rescue Plan.
Hi, everyone. I'm Jen with the Hawaii After School Alliance. Thank you all for joining us here today.
So this is great news that I wanted to share with all of you. So you might have known that the American Rescue Plan was signed into law by President Biden. And we are very, very excited because there is a specific language about after school programs and summer enrichment programs in the plan. And the numbers that you see in the slide are the amount of dollars that the Hawaii will be receiving in the next 2 months to support programs to address learning loss. So out of that funding, we are going to be advocating for this funding to be used in a very strategic way and to support especially our most vulnerable students and especially the kids who are needing the extra help to be successful. And I just wanted to share this because it's great news and we are very, very thrilled to see that language included in the plan. So if you have any questions about the plan, please don't hesitate to contact us and we can talk more about this. But before going into more details, I would like to introduce CJ Johnson, who is here from the Hawaii Department of Education. CJ is a native Hawaiian and Pacific Islander and Filipino COVID-19 outreach and public health education specialist for the Department of Health. And his mission is to develop community partnerships to ensure that the department's COVID-19 guidelines is timely, accurate, and informed by community needs, and that trusted community leaders have the access to information and resources they need to educate and engage their communities. So thank you so much, CJ, for being with us, and please take it away.
Oh, thank you so much. I appreciate it. Every time I hear someone do that, I realize I got to go back and like put some periods in there, right? That's quite a run-on sentence. I apologize for that, but thank you so much. I'm going to try to share my screen real quick and we can get going. Is my screen showing? Does everybody see that? Okay, perfect. So yeah, my name is CJ. I'm with the Department of Health, COVID Outreach and Public Health Education. project at the Hawaii State Department of Health. So I do want to share up front that things are, I'm actually going to turn off my screen because all I'm doing, or my video, because all I do during this is read. So I want to share up front that things are changing really quickly. I present this show that you're going to see here multiple times a week since December, and I don't think I've ever given the same one twice. Like it's, the information is really dynamic. Probably you can tell that from the news that's going on. And that's even more so this week than normal. It's really wild. And I also want to share that there's a couple of big questions, and I'll get to these in order, but just know that there's a few things out there that are really big, outstanding questions that we just don't know the answer to yet, that are really important to kind of the future. And so there's a lot of question marks. The road ahead, I think, is looking more positive than it has in quite a while. But even given that, there's a lot of things that we don't know, and we'll go over those when we get to them. But the best way to make sure, outside of having me in or calling me up, to make sure that you have the best and latest information, is the Department of Health has a webpage, hawaiicovid19.com, where we keep a lot of information. We put a lot of effort into the site. We're really proud of the stuff that's there. One of the main things there is how to register. It is not itself a registration portal. We don't have a registration portal yet. We are working on one, but we do have links to all of the other registration options across the state. So if you're eligible, which is expanding, we'll get into that, please check that out, and it'll show you how to get registered and where to go to get your vaccine. We also have translated FAQs if you have, if you prefer getting your information in another language, or you have a friend or family member or serve folks that speak other languages primarily. Please check those out. We've got a lot of them. I think we do 16 to 20 languages as a matter of course, and that includes our frequently asked questions. That includes all of our hygiene guidance. That includes our brochure about the vaccine and what to expect. Most of what I'm going to answer here today is available. We try to keep up with it. We also have a really good data dashboard that shows kind of where we're at with everything. I did this screen cap a couple days ago, so that 416,000 doses is a little bit out of date. We're doing a bunch every day, but that gives you an idea, right? It's a really good dashboard. There's a lot of information on there. It shows you what phase we're in, how things are. Somebody's not muted and talking. If you wouldn't mind muting yourself, that would be great. But it breaks down by county. It breaks down by first shot, second shot completed. It's a really great dashboard. I really encourage everybody to check that out. So again, hawaiicovid19.com is a really great place to bookmark. And also you can subscribe, get updates, social media. We're really active on Facebook, Twitter. I think we're active on Instagram even, but we're trying hard to make sure that we're getting the messages out there in a timely way. So if there's one thing that I would really like everybody to take away from today, is that everybody that wants a vaccination is going to get vaccinated. And I think that the rate things are going now, it's going to be probably quicker than you think. We're really moving quickly. There have been some challenges over the last couple months with consistency of supply and volume of supply, but with a new administration and a new vaccine out there in the market, things are all pointing in the right direction. We have a lot more coming in. You've heard that the federal government is being really optimistic about everybody being eligible in May, and maybe we'll be back to normal by the 4th of July. I hope that's true. We're being a little bit more conservative in our projections than that, but that's, certainly the president is saying that, so fingers crossed. But everybody's going to get vaccinated. So I do like to start by clarifying actually what a vaccine is. And I think the way I like to describe it is thinking of a vaccine as a shield to defend your body against a disease before you catch it. It's not preventative, right? A vaccine won't help a person who has a disease recover or reduce their symptoms, but it will greatly reduce the chance that you will get sick or die if you were exposed to the disease. That's really important. Our goal from the public health perspective, what we're really working on is herd immunity. You've probably heard that term. What do we mean when we say herd immunity? Well, herd immunity is when the entire community, whether that's a city or an island or a country, is immune to an infectious disease, either from previous infection or from vaccination. And I use this image to describe that. And what we're looking at here, so imagine that our little red characters here are our infectious folks, right? These are people that have the disease and they're coughing and they're spreading the disease. Now then imagine that the blue people around them are the folks that have been vaccinated. Well, we can see that not everybody has been vaccinated, but enough people have been vaccinated that it makes it much harder for the disease to spread to people that haven't. And so that's the state that we call herd immunity. It's not every single person being vaccinated. It's just enough of the population vaccinated that the disease is very hard, that it doesn't transmit very easily. Of course, the next question, right? This is one of these things that we don't know yet, is what does that percentage look like? How many people? We don't know. There have been estimates that it's anywhere from 70 to 85% of the population would need to be immune. And again, that's either through vaccination or through natural immunity for herd immunity to be complete. So here we are. This is one of those things that changes really frequently. Right now, there are 3 vaccines in use that'll protect against COVID-19. They are made by Pfizer BioNTech. I'll usually just call that Pfizer. So if I say Pfizer, I'm talking about the Pfizer BioNTech, Moderna, and Johnson and Johnson. There are others that are being studied. There's more that are probably going to happen in the next month or two that we're going to hear about. But these are the only 3 that are approved for use right now in the US. So taking a step back, conventionally vaccines, like when you get your flu shot or any of these other vaccines that we take to get into school or whatever, those vaccines typically historically have used dead or inactive samples of viruses to train our bodies how to fight diseases. In fact, there's a whole thing about how smallpox, the original smallpox vaccine was just like rubbing cowpox into people's open sores or scratching them and putting it in there. That was the invention of the vaccine, how it used to work. We're a lot more sophisticated today in the way we do vaccination. There's a couple of different new technologies that are being used for these vaccines that we're really excited about. Viral vector vaccines, like the Johnson & Johnson vaccines, use modified version of a different virus as a vector to deliver instructions to the cell on how to fight the disease. So that vaccine doesn't cause the infection of either COVID or the virus that is used as the vector. So the way I've been kind of describing it to help visualize it is it's like a sheep in wolf's clothing, right? It's the opposite of that. It's a harmless disease, it's a harmless virus that gets injected, but it has instructions for your cells about how to be prepared and what to be on the lookout for when it does see a COVID virus. The other new technology is the mRNA technology. That's probably one you've been hearing about for a couple months now. The Pfizer vaccine and the Moderna vaccine both use mRNA technology, which is messenger RNA. So that's a little bit more like a wanted poster or a photograph of the disease. So we inject the instructions and it doesn't actually contain the virus at all. It just contains information about the virus. And it says, hey, if you see this guy in the future, don't let him in. And so neither of these vaccines actually include live virus, so they can't make you sick. People also ask sometimes, like, "Oh, RNA, mRNA, does that mean that it can affect your DNA?" So these vaccines don't actually get into the nucleus of your cells, into the center of your cells, which is where your DNA lives. So they don't affect your DNA in any way. They're just strictly interacting with your immune system and not with your actual DNA. So don't worry about that. A lot has been said about the efficacy of the various vaccines. I want to be clear, though, because the trials were constructed differently, right? The way that they conducted the clinical trials around these first 2 vaccines and versus the Johnson & Johnson vaccine, it's really hard to compare them meaningfully. It's a little bit like comparing apples and oranges. And especially because when the Pfizer and Moderna vaccines were being tested, we weren't dealing with these variants like the UK variant, the South Africa variant, and the Brazil variant. And Johnson & Johnson, when it was tested, was actually tested in an environment where we were already seeing some of this new strains that were maybe a little bit more resistant or weren't responding quite as well to the vaccine. So what you're hearing about, oh, this one's more efficacious than the other one, they're actually all really efficacious. They all do their job really well. And in fact, specifically, Johnson & Johnson was shown to be 85% effective at preventing severe disease. But I think more importantly, the really key point here about Johnson & Johnson is there were no hospitalizations or deaths from participants in the Johnson & Johnson trials after they developed their immunity. And I want to be really, I want to say that again, none. They didn't have any hospitalizations or deaths. So however else that you might measure it, what we're really trying to solve here, what we're really trying to prevent here is hospitalization and death. And the Johnson & Johnson vaccine is known to be very effective at that. So, I know people have said like, oh, I don't want to get the Johnson & Johnson, I want to get the real thing. And they're real. It's a real vaccine. What we've been telling folks is the best vaccine is the one you can get now. So don't hold out for 2 weeks for another one. Another thing is, and probably heard this, the Pfizer, BioNTech, and Moderna vaccines are 2-dose vaccines. So with Pfizer, you have to get a first shot, and then you wait 3 weeks to get a second shot, and then 2 weeks after that, you're considered to be fully immunized. Moderna, it's 4 weeks, and then 2 weeks after that, you're fully immunized. So what that means is from the first shot, it's 5 to 6 weeks before you're actually immunized, right? Before you have the full benefit of that immunization. Johnson & Johnson's 1 shot, you're considered to be fully immunized 2 weeks after that 1 shot. So that is a full month faster than the Moderna vaccine immunization. And a lot, as we know, can happen in a month. So again, there's a really strong benefit to that. That's one of the things we like to encourage. Another one is on the kind of the logistical end of it. The old vaccines, the mRNA vaccines, have a much more onerous storage and transmission and transportation requirements because they require deeper freezing, right? So that makes getting it here. Obviously, we have a very brittle supply chain, being an island in the middle of nowhere, and keeping things in these deep refrigerated states is very challenging, very resource intensive. Johnson and Johnson requires standard pharmaceutical grade refrigeration. So every clinic, every healthcare facility in the state has the refrigeration capacity to handle the Johnson and Johnson virus. So you combine that with the fact that it's one dose, you can see that there's a lot of populations and there's a lot of applications where Johnson and Johnson makes really good sense, especially again our goal is just shots in arms and getting people to that full immunity faster. So there's a lot of benefit to that. There's a lot of benefit to using any one of the three. This is one we get a lot. I know people are really interested in the kind of the order and how the order happens, and I want to kind of walk through from the top a little bit, because I think it's important to start with how the decision, how the factors get weighed in making a decision. So the decision on how to prioritize starts with the Centers for Disease Control, and the Centers for Disease Control breaks down what we'll call risks, the different, like there's more than one form of risk from COVID-19, and they have these 4 risk categories defined. So in going through these 4 risk categories, they're not ranked. The first one isn't the most. It's just these are the 4 kind of competing or balancing risk categories that go into the decision of who gets vaccinated first. First one is the risk of contracting COVID. So the people that would be obviously at higher risk than the baseline population of contracting COVID are people who work in direct patient care in hospitals and nursing homes, or people who handle biological waste in hospitals and nursing homes. So that's folks like doctors, nurses, clinical staff, custodial staff, folks that are in that direct exposure to the people and the bodily waste that the bodily fluids and waste that are likely to contain the COVID virus, right? That's one form of risk. Second form of risk, probably one everybody's really familiar with by now, right, is risk of serious outcome or death if infected. So these are people who, because of factors like age or chronic disease incidence, are more likely, if they are infected, to have a more serious outcome or to die if they're infected by COVID. That's folks like seniors, people with chronic diseases like diabetes, hypertension, COPD. There's actually a longer list of those on the website, on the Hawaii COVID-19 website. That's a good list of all of the kind of comorbidities that makes someone more likely to have a bad outcome if they get infected. So that's the second risk factor. The third, and this is one that's a little bit more tricky, I think maybe people aren't as comfortable with this one, but the risk of negative societal impact. And what this means is independent of your age or independent of your risk of of how sick you're going to get or how likely you are to get sick, the idea here is that there are certain people in society who, because of their job, because of the sensitivity of the job, it would be really bad if that population was unable to get to work or was incapacitated because of COVID. And there's a lot of those. And it's not like we don't like the term, I don't like the term essential workers particularly, but you can imagine that there's tiers of folks who, if they were to become, there's very few of them and they have very critical work. And if they were to become incapacitated, it'd be really disruptive. So some examples of that are harbor workers. Obviously, in a state like Hawaii, harbor workers are really important for keeping our supply chains alive. Postal workers, transit workers, our elected officials. I know not everybody's a big fan of our elected officials, but certainly they're managing getting resources out right now, right, in a really sensitive way, and making sure there's relief money and things are moving forward. Utility workers, air traffic controllers. So all those folks that's just some examples, but some of the folks that if they were to get sick, it would be really devastating for society. And then the fourth is risk of spreading COVID to others. And that has a lot to do with environmental factors like where you live and particularly congregate housing, like correctional facilities, large households, dormitories, shelters. So you take all those, you put them together, and then the Hawaii State Department of Health has a team that it's created that's essentially a set of experts that give advice and give recommendations via a working group back to the Department of Health. And the Department of Health has these phases, and the phases look very similar to the phases in other states as recommended by CDC. You've probably heard us talking about them. I'll go through fairly quickly on what they are, and I'm not going to read each category. And again, there's more information on our website. But phase 1A was the phase that first started in December, within days of the first vaccines being available. That's healthcare workers, the folks we talked about earlier, and long-term care facility residents. I would really like to call out one thing particular here is that everything else that's going on, there's a lot of work to be done. We've had some wins and some losses, and some things we're struggling with, some things we're doing really well. We have over 90% of long-term care facility residents in the state of Hawaii have already been vaccinated. We are the leading state in the nation for vaccinating our long-term care facility residents. The mobilization that has taken place pretty quietly, pretty behind the scenes to get that done has been absolutely remarkable. And it's something we should all be really proud of. And also it's something that we're already starting to see in terms of the hospitalization rates and death rates. We know a lot of our cases come from long-term care facilities. And so we are seeing less of them coming from there. So that's really, really exciting. But again, that's a big population, right? That's 50,000 people just in that phase 1A. Phase 1B, we're already editing phase 1B. So originally it was folks 75 and over. We've just changed it to 70 and over are eligible under phase 1B. And then that list of frontline essential workers. And this is the smaller subset under essential workers. But this is the folks like first responders, corrections, emergency services, essential government, critical transportation, critical utilities, teachers, childcare, and educational support staff like the folks on this call, and postal service employees. So that's 50,000 people plus 149,000 people. So that's another 200,000 on top of the 50,000 that was already there. So that's 250,000 people just in that 1A and 1B, right? A lot of folks. And then phase 1C, which we just announced yesterday, it's very exciting that we're going to launch phase 1C starting March 15th, starting Monday. Phase 1C is kicking off, and that is adults 65 and over, and then individuals with authorized ages with comorbid and underlying conditions. We will be sharing more information about what specific conditions those are. I don't think we have the full list published yet, but we're working on that. And then essential workers, the larger category of essential workers that are considered essential but are not in that essential frontline worker category. So that is a huge group, right? That 250,000 we already said, and then the 500,000 here is like well over half of the eligible population in the state. Because again, we're taking off kids under 16 and folks who are getting their vaccine through the Department of Defense or through the Veterans Administration is kind of a separate pot. So when you take all those out, this 1A, 1B, and 1C is a huge percentage of the population. And then we are still really optimistic about phase 2, which is the general public. Everybody else who hasn't already been discussed is going to be hopefully early summer. We're going to start. And like I said, the president is pushing for the 4th of July being a big celebration. We'll see if it goes that well. I hope it does. I think maybe we're a little bit more conservative. We hope to do it over the summer. So at times phases can overlap. And I think this is a thing where people are wondering like, well, I thought we were in phase 1A, but this person from phase 1B or this population is this and that or the other. And I want to be really clear that this is a visualization that gets used, right? These kind of equivalent pieces. But the reality of how phases work looks a lot more like this, right? They're not the same size. We just saw how much bigger phase 1B is than A and C is than B. And also we're having considerable overlap. Really the goal is that we want to minimize the kind of the downtime or the time when the enthusiasm and the demand in a phase starts to maybe taper off. That's the trigger for starting the next phase, right? It's not when every single person in phase 1A is finished, we wait and then we go to phase 1B. We want to really make sure that we're doing everything that we can to manage supply and demand similarly and to make more people eligible as supply increases. So don't be concerned if it seems like maybe on one island or one population is a little bit ahead or a little bit behind. We're trying to make it so that we're just keeping up with demand. There's a bunch of different ways that we're getting things out. I think the points of dispensing have been a really big topic. A lot of people are familiar with the pods or the points of dispensing, and that's how a lot of it's happening. They're obviously designed to be centrally located venues that have the ability to process large numbers of people. So we're talking about event centers, schools, and sports venues. The big famous ones on Oahu, who of course are Pier 2 and the Blaisdell Center have been our longstanding pods. And those are, again, just designed to be able to do a lot of people, because what is that goal, right? It's the herd immunity. It's getting a lot of people vaccinated, and that's one of the strategies for doing that. The other one is long-term care facilities. I mentioned earlier that we've done a really good job there, and that job is nearly complete. We're really excited about that. And then, oh, I'm sorry, did I skip? Yeah, long-term care facilities. Then the third piece is federally qualified health centers. So if you're not familiar with federally qualified health centers, we also call them community health centers a lot of times. These are more than just hospitals or clinics. They're medical facilities that are specifically located in high-need communities, whether that's socioeconomic distress or other factors, if they're rurally located where they don't have access to a larger hospital. We have them throughout the state, community health centers. They actually receive a direct supply from the state, and they're actually going to be receiving a direct federal allocation starting here, I think, in the next week or two. They're really, really key partners. I think one of the things that we get asked about a lot, and one of my key job roles is that Native Hawaiian, Pacific Islander, and Filipino health and outreach. That we know that those populations in particular are overburdened by a lot of chronic diseases. They're also overburdened by COVID. They've also been a population that we've been struggling with in terms of vaccination and making sure that they have access to vaccine. But the federally qualified health centers have been a really important strategy, a really important part of that. They're continuing to be so. They know their communities really well. They serve the communities that are already being hit really hard. And so our role has been really to try to help do everything we can to make sure they're able to outreach to everybody in their neighborhoods and communities that needs to, whether that's language outreach or supporting with volunteers or community organizations. But they're a really big part of it. And then the fourth thing, which we're really excited about, and this is about a month old, is the federal retail pharmacy program. So in Hawaii, Longs is our federal pharmacy partner. And this screen cap I took, they happen to be all booked, but they're replenishing the supply pretty regularly. But if you go to the local Longs site, they actually have appointments available for anybody who's eligible. So starting on Monday, that'll be anybody in 1C, but for now it's 1B. And I'm actually also told that if you're 75 and over, you could just walk up. So not everybody, but 75 and over can just walk up, no need make appointment. You can just walk up there. And they also are, and this is a thing that I was specifically encouraged to remind these folks, if you're in this group, if you're After School Alliance folks, you are eligible under 1B. If you're waiting to hear back from the Department of Health, I know that they have a pretty long queue and a long waiting list. But you want to get in now and you have access to one of those sites or you're near one of those sites, they'll see you now. You can actually get vaccinated through that federal retail pharmacy program. So that's a really important part of our process that helps take the pressure and the long lines off of some of the others that take a little bit more resources and logistics. So we're really excited. They're scaling up really quickly. We originally thought they were just going to be a small trickle, but they're actually turning into a growing stream of vaccination availability. So it's really great. So when you sign up, it's really important to get your first and second shot in the same area. And what I mean by that is the same state or possibly even the same location, right? The reason is that the federal government allocates by population, and then first and second doses are actually managed in a different way as our first and second appointments. So it's really important that if you have travel plans, if you're either on the mainland, you're coming home, or you're going on vacation, and you're thinking, oh, maybe I'll get vaccinated while I'm in California or whatever, make sure that you either delay your travel plans or your vaccination so that you can get both doses if you're doing a 2-dose vaccine in the same place. It's going to be really hard for them to process you if you show up in California or you come from California to here and you say, oh, I already got my first one. They won't have a record of that in state. And so it's very challenging to get you in that. It's really disruptive. And so we really are encouraging folks to do the same place. You'll need to bring your ID to the site. If you don't have an in-state ID, if you do not have in-state driver's license or in-state identification, do be prepared to show some proof of residence. And that can be as simple as a lease or insurance papers or a utility bill, just something with your name on it. You know, they're not trying to gatekeep. They're not trying to make it difficult. They just kind of want a little bit of confirmation that you're in the right place, but just show something that shows that you're local. And then once you are on site, there's a checklist that it's a CDC screening form that's just some questions about health and background and age and those kinds of things that you'll be expected to fill out. We're asking people or encouraging people to check out that checklist before they go in just to see what's in it, and then they won't be surprised when they get there. We have that again on HawaiiCovid19.com. We also have that translated into 20 languages. So if anybody again has anyone that prefers to get their health information or answer questions in a language other than English, we've made that a little bit easier for folks to do. Once you are vaccinated, you will get a card. It looks a little bit like this card that'll have your info, and it'll have a follow-up shot information. So when you're supposed to come back, make sure you write that down. Keep that card. They have a lot number that they put on there that is actually going to be pretty valuable. If you lose it, they can replace that. They can give you your lot number. I've heard people say take a photo of both sides of it as soon as you get it, just in case you lose it. They can also recover the information online if you do lose it. It's not the end of the world. But we are asking folks to keep an eye on it. It is a personal health record. And then once you get vaccinated, you'll be asked to hang out for 15 minutes just to make sure you don't have a reaction. There are folks that have said they want to get vaccinated even though they know they have some of the allergies that are counter-advised, and that's fine. If they are making an informed decision, we'll vaccinate them, and then what happens is they're asked to hang out for 30 minutes instead of 15. We've actually had such, not here in the state, but I'm aware of nationally folks that have said, you know what, I know I have a reaction to some of these ingredients. I really think it's important anyway, so I'm going to do it. I'm going to have my EpiPen on hand and get vaccinated, and then just go through that, and then I'll be vaccinated. So that's a thing that's actually happened. That's allowed. They'll do it if you want, and I think that's great. But we do, make sure that people are making an informed decision. Once you have received, I'm sorry, some people have who've been vaccinated do experience side effects. They are normal. They are expected. They are your body learning to fight the infection and reacting to the intruder. They're pretty typical flu-like symptoms. Also, there's soreness at the site of injection at the location site, but then on top of that, it's flu-like stuff like fever, headaches, body aches, fatigue are very common. They're typically pretty mild. I had my shot a couple weeks ago. I did not take off work. It was just kind of an achy, heavy eyelid sort of day. I didn't feel great, but it wasn't so bad that I was, laid up or anything. Most of the folks that I've talked to had a pretty similar experience. Just was kind of uncomfortable. It usually doesn't last more than 3 days, 1 to 3 days. My first shot was 1 day. My second shot was maybe 2 days, where I just felt like I hadn't gotten a very good night's sleep. Rare are very serious side effects, and what we also are telling folks is that the likelihood that you have an allergy without knowing it is very low. Most people that have allergies to these ingredients or would have a reaction or have serious side effects probably know what underlying conditions that they have that might make them likely to have an adverse reaction. So don't sweat that you're going to have a serious adverse reaction. If you do, you probably know what would cause that. There's two ways people become immune to COVID-19. One is through the vaccine. The other is through the disease itself, which is called natural immunity. The vaccine is new. The disease is new. Because of that, we don't know how long either of those things last, unfortunately. Evidence suggests, the evidence that's coming together right now suggests that natural immunity might not last super long. It might be on the order of months before that starts to fade. And again, we don't think that it's a hard line where like one day you're fine, the next day you're no longer immune. It seems to decay over time. But we do also think that vaccine-induced immunity, is both more robust and lasts longer. But again, because these things are new, we don't know how long. I know that one of the questions that was asked in advance of this was, does this mean that we're going to have to get periodic boosters for COVID? I don't think any decision like that has been made yet. I think that the real goal right now is containment and eliminating the getting that herd immunity. And the faster we do that, the faster we'll be able to kind of take a breath and look and see, okay, well, what does this mean long term? There has been a lot of speculation that this could evolve even as it mutates into a more contagious disease. It could very likely also mutate into a less dangerous disease and become something that is more akin to the seasonal flu or even the common cold. And it would be something that we would recommend vaccination for vulnerable folks. But all that stuff is down the road. We really don't know anything other than the sooner we get the population vaccinated and we get herd immunity, the more breathing room we have to figure out what might be the long-term prognosis for that. We are still asking, if you've had both shots, we are still asking folks to mask in public, avoid crowds, avoid close contact with people outside your household generally, although I'll talk to an exception to that in a second. Again, we just don't know enough. It's a new vaccine, it's a new disease. There's a lot of unknowns about how it curbs transmission. So we're studying those things. We're erring on the side of being cautious, right? Being conservative about it. But we do know that most vaccines provide protection. The evidence is starting to accumulate, and we are getting very confident that once you are fully vaccinated, you are very unlikely to spread COVID to others. So that is reflected in some of the next guidance, which is there's kind of three things that have changed for our public health guidance around people that have been vaccinated. One is, if you are fully vaccinated, which means 2 weeks out from your second dose or your single Johnson & Johnson dose, you can gather indoors with other vaccinated people without wearing a mask. So that's safe. We consider that to be safe if both people have been vaccinated or all parties have been vaccinated. You can gather indoors with unvaccinated people from one other household at a time. So think of it as they have a bubble, you're entering into someone else's bubble, or another group is entering into your vaccinated bubble. They would still be considered to be in a bubble and unvaccinated, but you can interact with one other group or one other family at a time without you or they wearing a mask if they wouldn't ordinarily be wearing a mask. We would ask people not to do that if there's anybody in that household or any visitors that are in those increased risk groups. But other than that, that's one of the things that has eased. And then a third one, and this is kind of a big one, is if you have been exposed. So we have contact tracers that are, whenever someone is diagnosed with COVID or tests positive for COVID, they call around to all their contacts, coworkers, people they've interacted with in the last however long. And if you have a lot number from your vaccination, this is why I said save your card. You can provide a lot number that says I was vaccinated more than 2 weeks ago. You no longer have to isolate and go into self-isolation if you have been notified of exposure to COVID-19. So that's pretty big. That's a good perk for getting vaccinated. I know I got this question too. Do you still have to follow the safe travel rules? For now, the answer is yes. I expect that's probably going to change. I think we'll probably be addressing that. Obviously, if we're dealing with these other things, it seems like we're getting some confidence that you're not as likely to transmit. So I suspect that the safe travel stuff is probably going to be, there will be a vaccine exemption in the next month or two, but we haven't made any announcement about that yet. So for now, if you're planning on traveling this weekend, we still are going to ask vaccinated folks to travel using the Hawaii safe travel rules. Still important to get your flu shot. It does have benefits. It keeps you from getting sick with the flu. It reduces the severity of the illness if you do get the flu, reduces the risk of hospitalization if you get the flu. It's important to keep you healthy and to keep our clinics and hospitals from being overrun. I think that's a really important part, right? They will help us keep our hospitals and clinics from being overrun during a pandemic, but they will not keep you from getting COVID. It is 2 different vaccines. It is 2 different diseases. So we are still asking folks to both get their routine flu shot if they haven't already, and also to get their COVID vaccination. The one caveat there is that they do ask for a 2-week buffer between them. So if you got your flu shot yesterday, wait until 2 weeks have passed before you schedule your COVID shot. Or if you've just gotten your second dose of your COVID shot, wait for another couple of weeks before you get your flu shot, and don't get it in between, obviously, either. But that's the only recommendation there. How you know, we are broadcasting on all channels, right? We are working with healthcare providers, TV, radio, newspaper, tons and tons of community partners that have language access, that have cultural connections. We're working with churches and religious partners. We're doing everything we can to make sure that everybody knows and everybody gets the word when it's their turn. If you're an essential worker, I know a lot of the folks on this call, I think everybody maybe on this call either has been notified or is going to be notified. Please be patient. They are processing a ton of folks. But everybody's going to get notified about when and where to go. Stay tuned. If you're not, or maybe you are, but you have a loved one, just stay tuned to the local media. Subscribe to our newsletter. We'll let people know when it's their turn and how to get vaccinated when they're eligible. We do have challenges. The remoteness and the brittleness of our supply chain is a big challenge. Trying to do these events without having crowds, right? That's a big challenge. You want to have these big mass vaccination events, but you don't want people lining up at 6 a.m. in groups of 100 waiting for their turn. So figuring out logistics of how to get people in and out mostly by appointment. The different supply chains, there's the 2-dose with 3 weeks, the 2-dose with 4 weeks, and then the 1-dose. Keeping those separated is a challenge. I know some people are asking, how can I decide which one I get? Our line is the best vaccine is the one you can get first. So go to the place where you can get vaccinated and get vaccinated as soon as you are eligible and able to. The vaccines are negligibly different other than that in terms of the long goal, the finish line of getting us to herd immunity. I think there's probably going to be a point in the future when we get into that category 2, where maybe there's some consumer choice where you can go because you know that one place has the Johnson & Johnson, you want that, or you don't want the Johnson & Johnson, or you want the Pfizer or whatever. At this point, I would really, really encourage people not to get hung up on that and to go with whatever you can get access to. And those are the challenges, but everything is kind of starting to lock in place. I think we're moving really strongly in the right direction. So to close, I just want to say, everybody who wants to get vaccinated, like I said at the beginning, will get vaccinated. Everybody has a role to play. If you've already been vaccinated, there's volunteer opportunities, there's community organizations that are coming together. If you've got a kapuna in your neighborhood that isn't online, that's eligible, that maybe needs a ride to the site, reach out and see what you can do, how you can help out, help somebody fill out the form online. We're trying to make it easier. It is hard translating CDC speak into other languages. Even translating into being more accessible to non-public health PhDs is really challenging. And then we have the language challenges in the state. So anything you do to help get folks in the door, help people sign up, that's really appreciated. But for now, I really appreciate everybody's time. I know it's a lot. I know there's a ton of information, but I'm happy to answer questions. I think there's some questions in the chat. So thank you so much for your time. Thanks for having me. And I will stop sharing my screen and reshare my video.
Thank you so much, CJ. Yeah, there are 2 questions in the chat. I can read them for you, or maybe you can read them yourself.
Sure. So the first question, oh, hold on a second. Okay, so the first question I see is it true that the Pfizer vaccine is more effective? Again, that kind of goes back to, there's a little bit of an apples and oranges things, because the way that the first set of trials was designed and what it was studying and measuring is very different from what the Johnson & Johnson trial was measuring. What we're trying to do, what the public health goal for this is to get the most people immune to the disease and not transmitting it, not catching, not dying from, not being hospitalized, and not transmitting the disease as soon as possible. So there are trade-offs. There are some benefits to Johnson & Johnson, which again, like I said, you are fully vaccinated 2 weeks after your first shot. That's a huge deal, right? In a month, think of how many people in the US are being diagnosed or being exposed to COVID in a month. So if you get Johnson & Johnson, you're that much closer to not being able to be transmitting or hospitalized or die from COVID. The Pfizer is a very, very good vaccine. We are seeing that it seems to be very effective at preventing people from getting sick and from preventing spread, but all of them are doing a really good job at keeping people from getting hospitalized and from dying from COVID. So apples and oranges. And then the next question I saw in there was, how does a person who was vaccinated in January and was recently found COVID positive fit in the quest for herd immunity? That's why it's a hurry. That's the big question. So there's a couple of things. No vaccine is 100% effective. The very effective vaccines, especially at stopping someone from catching COVID, the very effective vaccines, the Johnson & Johnson and Pfizer, were considered to be 95% effective at stopping that transmission or stopping that infection. So what that means is if you vaccinate 100 people, 95 of those people will not be capable of getting infected with COVID after, well, let me restate that, will not be symptomatic, will not show any signs of getting COVID. As a result, they're immune to getting sick from the COVID disease after they've been vaccinated. That's not 100%, right? There's still a possibility that there's always going to be a small amount of people who are resistant to the vaccine and are still able to get sick. So I wouldn't be too concerned about that. I know that when we see those kinds of stories, it is alarming. There's a number of reasons could have caused that. There's a number of things could have caused that. I wouldn't assume that it's because that natural immunity wore off. They could have been, we hear one story and that's an outlier so far. So I wouldn't worry too much about that. Oh, and then
Joy, yeah, Joy, I think you would like to ask a question.
Hi. First of all, thank you so much for holding this event. It's really helpful. I work for a small nonprofit, and we do we usually will go into high schools but obviously because of COVID, we've been doing distance learning from home. Technically, we're teachers, but we're not, because we're not with the DOE or with a specific school. My boss wasn't sure if we would qualify to be able to get vaccinated sooner. So are we, even if we're working from home, are we still able to get the vaccine, or do we have to wait with the rest of the?
So if you are going to be back in direct contact with students when school starts back up, then we would consider you 1B, and we would consider you eligible when that happens. I think if it's 3 months down the road that you're going to be back, then right. I mean, just as a matter of principle, you're not. I wouldn't rush. But if right. you are going to be exposed, yeah, we would absolutely consider you 1B. And we have a form that I shared, I think, with Paula and some others, that the employer can fill out everyone and then send that form as. And I really want to, I think some of you have that. Don't fill out that form as individuals. It's really important to fill it out as an institution, and then have that institution list all the employees, even if it's a small institution, and then they will reach back out. I was just talking actually before, just in preparation for this, with there's one person who's going through these, and it's a lot, and they're working really hard on it. But we're a lot going on. But anyway, so they'll get back to you and they'll schedule you. I would encourage folks, if you do have access to a Longs, if you're near a Longs or can get to a Longs, to do that, because it'll be quicker and easier. Because Longs is not filling up their slots consistently every single day, so you should be able to get in and out of Longs pretty easy.
Oh, so you can get it at Longs.
Yes, you can. Yeah, if you're 1B, if you're a teacher or work in education, you are. I'll make that point again, right? Anybody who's on this call who works in education, who works with DOE, who is involved with students, who has contact with students, you're considered 1B. You should be able to go into Longs, or actually, rather, I should say, go to the website and sign up and go to Longs and get your vaccination.
And so, is that link for that form in the chat?
I can try to dig it up. I don't have it handy right now, but I'll dig it up and try to put it in before we're done, or we can send it to you after.
Okay,
but so it's just go to Longs, CVS, vaccine, and it's on there.
Right. And do you know about, I know this is possibly a dumb question, but I know one person going through all of these forms, about what's the wait time, do you think, just so I can let my boss know what the wait time is on that?
I specifically asked that question, and she said it really does vary, and we're going as fast as we can because some of the orgs are huge. I'm really sorry. I know that's a super but they said we don't know. We're going, they don't know before they open one if there's 150 people on the list or 6. So it's really just hard to say even that much. So thank you for your patience, and they really are going through much.
Thank you.
Yeah.
So CJ, there is another questions in the chat.
Okay, I'm looking through here.
Okay.
how does it work that a vaccinated person is not likely to spread the virus? I guess the question is, how does the virus spread? That's a great question. So the virus essentially spreads by getting a hook into your respiratory system, right? You breathe it in, you inhale it. Usually that's the overwhelmingly common way for you to get it is you inhale it. It gets your mucous membranes and your throat and your cheeks are very porous. They're very sensitive. They're very thin membranes. It's easy for it to get in that way, and it replicates in there. And then when you cough or sneeze or even talk, like loud talking and singing are actually things where when you talk, you expel respiratory fluid, right? Which is just the humidity and the water that you make and saliva and things like that. And there's a viral load when you are sick. When you get sick, that virus starts replicating within your saliva, within your mucous membranes, and then when you sneeze, when you talk, and then you expel that out, just your regular moisture that the humidity that you breathe out, it has a viral load in it. When you get vaccinated, there are a number of ways that the vaccine stops the virus, but one of them is making it harder for the virus to kind of get that toehold in the first place and start replicating. So the big question mark is the thing that we knew really quickly was that it stopped people from getting sick. So that was the first thing and this is where it gets really complicated. I could do a whole hour on this. And in fact, I'm not the expert on that part, but the bottom line is we had confidence very early that if people that got the vaccine, it would keep them from getting symptoms. They would keep them from being sick, from showing signs, from being hospitalized, from dying, right? So people would not report that they were sick. What we didn't know was whether if they were exposed that the virus would infect them and take hold, and they would be infected with coronavirus 19, but not have COVID as a disease. We are learning that it in fact does inhibit people from even catching the disease to an extent that it starts replicating within their system and being transmissible in their respiratory fluid and their respiratory transmission and mucous membranes and stuff. So it seems very likely to us at this point that people who have been vaccinated are not the virus is not replicating at sufficient volume in them, or if at all, that they become transmitters. And so we're not like 100% confident that it never happens, but it seems like it's happening considerably less in people that have been vaccinated.
Great. Thank you for that, CJ.
Yeah.
Romeo asked that question because as someone who works in a school, I'm always asked, we have kids around and they're like, the more information we can give our kids on how it works is really helpful.
Okay. For sure.
Okay.
Yeah, it's a tricky one. I think I have a longer presentation. This one was long enough, right? But there's a whole other longer thing about like what we mean when we say we're immune to it. And that's, initially what they wanted to do we're in a triage mode, right? Like this was a triage situation where it's like, we just want to stop people from getting sick and dying. So that was the original goal of the original set. And that was how they tested it, and it worked. So then they were like, okay, well, this will help people from getting sick and dying. Now, how well does it keep people from transmitting it? Because that's going to be really important too. And we believed, based on how mRNA works, that it was also going to do that because other mRNA therapies have, and other vaccine therapies like the viral vector therapy have. But you have to be conservative when you get these things out, and until it's proven, you have to err on the side of caution. And it looks increasingly like, I think the CDC saying that you no longer have to isolate once you're exposed if you are vaccinated is a sign that the CDC feels very confident that there's a significant damper to the transmission rate.
If I could continue, one of the other protocols that we do in schools is, we're wearing masks, both vaccinated. So everyone's wearing masks when they're in the school building. We have hand sanitation stations in front of every classroom and throughout the school. And we're also having, when students use computers or move from one class to another, we wipe down the tables. They wipe down their spaces. They wipe them down when they come in. Because early on, without the knowledge, maybe it's transmissible from surfaces. And so what is the thinking around that now? I mean, we'll probably continue to do it, but I'm wondering, has the thought about being transmitted from surface to people is still something to be aware of?
I mean, I think that a level of hygiene like that, especially with kids, right, is a good idea regardless.
But anyway.
Yeah. It certainly seems like, I think the evidence is really suggesting that droplet and airborne vectors are much more common than surface transmission, or what we call fomite transmission. So that's I touch something and then you touch something and then I put my fingers in my mouth. That doesn't seem to be happening much. It still is a recommended best practice to use that. And the school district has, guidance for COVID management. So I wouldn't, we do again err on the side of caution. It certainly isn't a bad idea to continue to sanitize things, if for no other reason than, it will keep people safe from other things that will keep the burden on our healthcare system low. And maybe these things will stick, right? Maybe we'll be hygienic in the longer term. But until that, and I think until the guidance changes to the DOE, I know I skimmed the DOE's book. It has a good COVID book that does include that stuff still. I would still go for it. I wouldn't stay up at night worrying about, oh, I touched a doorknob and then this kid's, snotted his hand all over it or whatever. Like, I don't think that's how people are getting sick with COVID. So don't be anxious about it, but certainly it's a good best practice.
Okay. And if I could ask one more back to back.
Yeah, bring it on.
Sorry.
Got a lot in here. I know I'm good. I don't know what people's time is. I don't have anything at 11, so I'll go as far as people want.
So in our classrooms, we have 6 foot distancing. And we've had that, and unfortunately our school, knock on, Naugahyde, our school has been open since August, and we've had in school and increasing numbers here in Hilo. So, that's great. Because some of our teachers now have been vaccinated and staff have been vaccinated, some of the teachers are thinking, well, how much is the 6 foot distance? Do we have to continue to adhere to that? Because the way that we've adjusted is that if the room capacity is 15, and once it gets over 15 in a particular classroom, then we start shuttling kids to an overflow area. So kids are coming out and going in, and for a teacher, elementary teacher in particular, it's hard to teach 2 different groups of kids or have kids continually rotating in and out. So in terms of the 6 foot distancing, I know right now we're still there with 6 foot distancing, but we tend to, knucklehead charter school people, we kind of go, well, we want to try this. And so some of our teachers are saying, if they're vaccinated, they feel comfortable bringing all the kids in at once, but still wearing masks, still sanitizing. What are your thoughts about that?
I certainly wouldn't say anything contrary to DOE's guidance. I mean, we work obviously with DOE on structuring that guidance. I think it's going to evolve. I think we're going to learn more, and I think things are going to change. But I would really strongly encourage people to, for now, to do everything they can to adhere to. And I know I understand what you're saying, but certainly I can't suggest that anybody cut corners with DOE best practices or DOH best practices.
Okay, thank you.
Yeah.
Thank you, Rama, for your questions. CJ, there are 2 more questions in the chat. Can you see them, or should I read?
Can. No, I got it.
Yeah.
So it looks like the next one that I see is, what's the best way to encourage people to get vaccine and address mistrust? It's a good question. I don't think there's any one answer to that. I think there's a couple of things. So when we do surveys, what we found early, right, in like November, December, is that Hawaii was actually better than most of the U.S., which was kind of nice to hear. So at our worst, we were looking at about 6 in 10 were pretty enthusiastic, and the other 4 were not as enthusiastic. I think it is more helpful, rather than looking at it as a yes or no, to look at the kind of more granular subcategories, which is there's 6 in 10 that are like, yeah, sign me up right now, and there's another 4 that are short of that. But within that 4 is really interesting, and within that 4, what we usually find is only about 1 in 10 will say, oh heck no, don't poke me, you're not going to do it. They're going to put microchips in me, or whatever, Bill Gates, something. That's a small population, and I don't, I think there's better uses of all of our time than trying to engage with some of that nonsense. It's that's not scientific. It's not grounded in any sort of scientific best practice. So what we like to do instead, I think, is there's that other maybe 2 or 3 out of 10 who have legitimate concerns. I would not want anyone who is not comfortable yet to feel bad or feel shamed that they're not enthusiastic and comfortable. We all have different risk profiles. We all have different relationships with medicine as an industry. We all culturally have different relationships. I think that's really important here, right? In Hawaii, in the US, there are the medical industry, the healthcare systems have different relationships with people based on race, based on ethnicity, based on gender. These all influence how enthusiastic we are about about new technology in medicine, about clinical trials, right? About new things like that. So I don't begrudge anybody wanting some time. We still have more demand than we have supply. If folks need another month and want to hear more before they make that decision, I'm here for them. And I'll put my email address in the chat and we can talk through it. I don't want to sell anybody on anything. I find the literature really convincing. I think that it does kind of sell itself. But if people want to wait, we're going to be here. It's going to take a while to get everybody anyway. So if it means hanging back and seeing more of your neighbors, more of your religious and spiritual influencers, more of your cultural influencers, more of your political leaders getting vaccinated, more of your neighbors, that's fine. We're not going to worry about that too much. So we're just plodding along. I think another thing is that misinformation tends to spring up when the people that are trusted in a community don't have good information. And I think sometimes there's a historic gap between cultural influencers and sort of science and medical health influencers. We've been really trying hard over the last several months to work with particularly religious leaders and other influencers in the community, maybe non-English speaking or low English proficiency groups, and saying, just trying to get a temperature on like, what are you hearing? What are people concerned about? Is there something we can do? Is there something we can do differently or better to make sure the message is available? Because we've been really effectively delivering a message in English that is, we're working on it. Please wait, please wait, please wait. You'll get yours eventually. But we haven't been, I think, as good at making sure that we're explaining why people need to wait or what this process looks like in other languages and in other cultures and in other venues. And of course, not being able to congregate online in person makes that even more challenging. So I think put all that together just means we're putting a premium on transparency. We're putting a premium on trying to get the information out in as many channels as possible, and trying to make sure people don't feel pressured or feel sold to or feel shamed for not wanting to get vaccinated yet. No rush on our part. We'll get there.
Thank you.
Yeah.
And there is another question regarding school.
Oh, so as a school, can we assist individuals who are service providers to get our school in getting their to our school to get their vaccines? I'm not sure. Whoever entered that. Oh, is that Romeo again? I'm not. I'm sorry. I read that wrong or something. What was your intent with that question?
So again, and actually we've started doing it anyway, but
yeah,
could benefit other schools is that because we have people that are coming in that are regular service providers to our school. The after school program, they manage that, combine the kids.
Mm-hmm.
We were able to get some of them on our list as
that's great.
So that's the question is, can schools that have regular documented service providers, or do we provide them a letter that says this person is a service provider to our school, please allow them to get a vaccine?
I put them on your list.
Yeah.
I really want to be clear too that none of these qualifications are intended to be gatekeeping, right? We don't want to keep people from getting vaccinated. Our goal really is to get everybody vaccinated. It's just a way of organizing it. My colleague John, who's one of our operations lead, is really fond of saying, if everybody's a priority, then nobody's a priority. And so to that end, what we mean is, like, when we ask for a lease or for an ID or for the school to submit paperwork on your behalf, it's not to keep someone from getting vaccinated. It's just to manage. It's just to try to keep the flow of people who are eligible aligned with the amount of supply, and that supply is increasing every week. We get a little bit more. So I don't see any problem with, if a school feels like vouching for somebody, put them on the list. That's fine. I don't think that's a problem at all. We don't want to stop somebody, especially working with kids, right? Like, we want people to get vaccinated. We just want to manage the line.
Okay. Mahalo.
Yeah.
So it's 11. I don't know if anybody has another question that we would like to ask. Otherwise, we would like, if you can give a round of applause to CJ, virtual applause. And thank you so much. I think Jen or Lexi are going to put the evaluation link in the chat. So if you can complete that evaluation, that would be great. So we know what we are doing right, but most importantly, how we can improve. But CJ, thank you so much. That was very useful, a lot of information and very clear at the same time. So thank you for being with us.
You're so welcome. I'm really grateful to do it. I'll do this anywhere. If anybody has a church group or a community group or a cultural group that they participate in that would benefit from this, please, I just put my info in the chat. I'm more than happy to share this information and answer questions for anybody that needs it. Thank you.
Thank you so much. And thank you so much, everybody, and have a wonderful weekend. And we'll see you next time, okay?
Take care.
Bye.